It's really exciting for me to be here today on this Terumo sponsored session. My name is Fadi Saab. I'm an interventional cardiologist from Advanced Cardiac and Vascular Centers of Amputation Prevention in Grand Rapids, Michigan. And I'm really honored and privileged here today to be joined by one of my two esteemed colleagues, two world authorities in the field of peripheral vascular disease, and particularly critical limb ischemia. All the way to the right is the one and only Dr. Chris LeSar, vascular surgeon, the CEO of the Vascular Institute of Chattanooga, Tennessee, really one of the pioneers in the field of critical limb ischemia, and I might say one of the leaders in the vascular surgery community when it comes to treatment of these patients with advanced disease. Immediately to my right, my colleague and friend, Dr. Ankur Lodha from Cardiovascular Institute of the South from Lafayette, Louisiana, one of the authorities actually in the R2P platform treatment, and it's really a treat for us to have him here today to talk to us about this important topic. So without further ado, I'm gonna kind of dive into this to set this up for our audience. We really wanna try to touch on all aspects in terms of treatment and revascularization of critical limb ischemia, and particularly when it comes to access points. So I'm going to start with asking you, Chris, what is your preferred approach to PAD treatment procedures in terms of endovascular versus surgical, since you're a surgeon and we have to ask you,
Sure.
audience?
I always say it this way, do the least harm to your patient, right? In surgery, there's always a significant recovery time. There's higher morbidity, mortality with operations than with a lot of the conventional, and the catheter-based technologies. So endovascular to me, in my world, is the first thing I do, it's the second thing I do, it's the third thing I do, and then surgery is my bailout to actually fix some of the problems that endovascular can't.
Why do you think, that's a very unique perspective. Again, you're very skilled when it comes to surgical endovascular approach. And obviously, like it or not, that does interfere in the decision-making process. Do you think that that's going to be a trend toward the future? Do you think that that's the minority right now? How do you feel about it?
I think if you're going to do complex critical limb care, you will tend to be an endovascular-focused person. The surgical aspects of it give me some advantages. The more you train, the more options you have, the more you can see. But there are certain cases that surgery cannot fix. When you do below the ankle reconstruction, distal tibial, surgery doesn't fix that problem. So the only thing that can is an endovascular approach. And in my critical limb people, about 15% of the time I'm below ankle. Well, they're non-surgical candidates in that particular time frame.
So you think because of the nature of the disease that we're seeing and what's expected from us as revascularization specialists, we need to push the envelope of endovascular therapy to, like you said, go below the ankle, go below the knee, sure, and provide the advantage to those patients. On that note, Ankur, how does your approach to CLI versus PAD differ?
Very good question. So we started off doing a lot of these cases in my training as femoral cases. And as we started to tackle more and more cases, we realized, as Chris pointed out, that safety of the patient comes in first, so we started adopting radial access. CLI patient is a very interesting part. In CLI, if I have distal vessels which are occluded, really difficult for me to reach, or my equipment to go from the radial, then we would probably try antegrade femoral approach in a lot of those cases. If I have particular ulcer territory which is there along the anterior tibial artery distribution, we have also used the posterior tibial access in those cases and gone around the tibioperoneal trunk down into the AT from the popliteal and try to do that as minimally invasive as possible.
So not to put words in your mouth, but basically what you're summarizing to us is you feel that the closer you are to the lesion, while you minimize the amount of complications related to the access, is probably the best of two worlds. So and we're gonna dedicate a significant topic of this discussion about your R2P approach and when do you choose it and which lesions do you go to. So let's switch gears a little bit to the term alternative access. And Chris, we hear that term quite a bit. Alternative access. And I personally don't like it. I think it's not alternative anymore. It's kind of like the go-to access. But Generally speaking, the term anterior axis refers to anything but common femoral artery, I guess. Or even if you want to be more specific, the only common axis per se is the retrograde common femoral artery axis, at least in the United States. So in your mind, when do you start thinking about alternative axis or additional access points?
Well, I think, I grew up in that, I was trained how to start with the common femoral. It was the big vessel, easy to target. It was probably because you didn't use ultrasound to actually target the vessel. You could actually feel the pulse, put the needle in, right? And that's why we could get access. Once we've gotten much more sophisticated with ultrasound, I think we realized that we can choose maybe SFA, which is just below common femoral, if the vessel's nice and healthy. If there's a complication like a bleed, you can treat it with a stent instead of having to go to surgery and fix it. We start realizing that maybe these vessels are better to use. You pioneered a lot of the work with the transtibial access, and I've been doing that for a number of years, and it's all because the technology's gotten better. So when Terumo came out with their slender technology for the sheath, it changed the game. It leapfrogged us forward to be able to do things like transtibial access reconstruction, or maybe transradial reconstruction. The 035 sheaths were too big; you could tear the artery, and that tapering of that sheath really, I think, was one of those pivotal moments for critical limb care.
I love that you mentioned that, and I don't think we talk about that enough. Yep. And Ankur, I'll be curious what your thought is, because one of the things that early on, and I say early on, 5 or 6 years ago, one of the biggest criticisms to pedal access is, hey, safety, 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 and rightfully so. As physicians, we do no harm, and we have to talk about it. The good news is the overwhelming body of evidence out there does not support that there is any high risk of complications related to pedal access. And I'm biased a little bit because I sense, I share Chris's opinion that having the hydrophilic tapered sheaths, low profile, really minimize the injury to these pretty sensitive tibial vessels, quite frankly. What's been your experience in terms of, a lot of people resist placing sheaths in these tibial vessels, thinking that it's less harmful. In my humble opinion, I think it's more harmful not to have a sheath and do flushing, proper flushing and anticoagulation. What's been your experience, Ankur, in that world? Truly,
compared to what you said, is we put a sheath in, and I think the Terumo slender technology, especially the 4-5 slender sheath, the 5-6 slender sheaths, we put them, and we've not had any clinical problems using that.
Do you think the design in terms of like the transition between the wire, the dilator, and the sheath, I mean, it's a regular sheath in the sense of size-wise.
Correct.
But the dilator and the tapering of a dilator to the wire, do you think that makes a difference in terms of creating any injury to the vessel wall?
I think there's less trauma, absolutely, because it's completely atraumatic. It's 018 when you put it in. The hydrophilicity, the smaller donut that it has. So if I can imagine that since you've got such a small outer covering, the donut is so thin and small, what kind of trauma it will be causing to the outside vessel. So in our clinical practice, we've not had any problems with tibial access.
Excellent points. So let's switch gears a little bit. All right. So we talked about approach to PAD, CLI. We talked about access. We talked about alternative access. Then the $1 million question, that we always get asked that where you're not on the podium. Hey, what do you use? What wire? What catheter? Chris, let me start with you. What's your strategy in terms of tackling chronic total occlusions? What wire do you start with? A workhorse wire? Do you start with a CTO wire? It depends. Give us your thoughts.
So I think we have our different wires that we're comfortable with. The top 5. There's the top 5. Probably not much more than that, really. I tend to do transtibial access for a lot of the CTOs. I'll use a catheter to get to that level of the CTO, so there's some support for the wire. And then I'm using a hydrophilic wire. And what I'm looking for, why I do that is because a lot of times there's a microchannel along that CTO which is the small channel that finally just closed. and then that hydrophilic wire can travel up. So I use a lot of V18 wires. That's a traditional wire I've used. The GlideWire Advantage, 018 GlideWire Advantage, I think is a great wire. I use that quite a bit. But I'm looking to get to travel along that lesion in that microchannel before I have to do subintimal or any kind of, where I have to knuckle the wire or anything like that. So I'm always trying to stay transluminal if I can, and I think that's about 20% of the time you're going to sail through that CTO with just that hydrophilic wire.
Gotcha.
And then I advance on to, I have command wires. It's another one I use a bit. Some of the dedicated wires from Asahi, the
CTO wires.
They're dedicated for that.
So to build on the comment that Chris mentioned, you said something that's very astute, and just goes to show you that the experience of an operator is he always tries to follow the wire with a support catheter.
Absolutely.
And you were building on this concept of a hibernating lumen, or at least relatively easier to cross these chronic total occlusions retrograde fashion. Ankur, how do you? I know that obviously there's a lot of support catheters out there, and one of the flagships of Terumo is the NaviCross catheter that I know all of us use in our practice. It's a double braided hydrophilic, really beautiful piece of engineering that I depend on heavily in my practice. I know all of you guys do the same. Can you describe a little bit more on what Chris was talking about in terms of marrying the catheter with the wire support technique?
Great. I mean, NaviCross catheters are my favorite catheters. I always take them out first. The 035R in an SFA total occlusion, I would say a CTO can be a predominantly calcified CTO or a non-calcified or less calcified CTOs. I use a NaviCross catheter and I point out a little bit of a wire out. It could, in a simple non-calcified lesion, if I feel that I can cross intraluminally, maybe point out a little bit of a glide wire advantage 035 out, and then use that NaviCross catheter and move it so that it finds a lumen kind of with
So
blunt
you're
vessel.
always marrying this wire catheter technique.
Yes.
And do you feel that affords you more control, more safety, more success? What do you think is the advantage in that approach? I think that's important for our audience to listen to.
I think when we do and marrying these catheters gives us more support, but at the same time, it is not like pushing a glide wire on its own where it goes out in the subintimal space. It kind of stays intraluminal throughout.
So you're controlling the force as you're delivering. And I think that's something a lot of us physicians struggle with as experience is gained. People maybe not necessarily verbalize that, but as experience is gained, they want to control the amount of force that they're delivering in a particular area. And having a catheter right there affords you to do that.
Absolutely.
Beautifully said. Thank you. Okay, so this is kind of a really 30,000-foot view question. So I want to ask you with a grain of salt. Stent, etherectomy, DCB, a mixture. Give us kind of the Chris LeSar approach to this.
So I think I think a lot of these lesions that we deal with, at least the ones I deal with in Tennessee, people who've been smoking since they've been 10 years old, is they're incredibly calcified. And I'm sure you guys are seeing those same kind of things. And they're incredibly long lesions. It's not the lesions that we see on the trials. This is completely different. And so atherectomy plays a major role in most of my patients. My ideal case is a transtibial case. I use ultrasound to find which is the dominant vessel in the foot. If it's the dominant vessel, it means it's probably been the one that's been feeding the longest. And if I can gain access to that, I'll drop a 6 or 7 French sheath in almost uniformly, depending on size of vessel. I think it protects the outflow. I can do embolization management with it. And then I fix the problem. And so it's usually atherectomy based. I don't leave residual stenosis, so I will stent if I need to. One problem I think we have is if we don't truly treat that vessel properly before you put a stent in, you're going to have a problem in a year, you're going to have a problem coming back. So I think aggressive treatment of those vessels are critical before you ever consider a stent. And then at the end of the case, I open the sheath, and if I have pulsatile flow, I've won. And that's how I know I've won.
Ankur, can you elaborate on what Dr. LeSar said? I think it's very important because some people might argue like, why are you wasting time? Just balloon and place a stent, for example. Why are you spending the time or using atherectomy prior? Why are you using vessel prep before? Can you take us through your thought process? Because I think what Chris mentioned is really essential, and not a lot of people actually focus on it. If you have a suboptimal stent result, I mean, ultimately the patient ends up paying the price. What are your thoughts on that?
Absolutely, and I completely agree with Chris. That's the kind of patient population we are seeing in the south where I practice. These lesions are calcified, they're very fibrous if it doesn't have that much calcium, but there's disease on a long length. If we just do a plain balloon angioplasty on these patients, the outcomes are not good. In our clinical practice and using our registry of patients that we've seen, these people come back in 3 to 6 months if we've not adequately done that. Going further with this point of stent, a stent opposition is very important if the vessel is prepped before. And even if a physician does not want a stent, if he wants to do a drug-coated balloon, it's very important for the vessel to be prepped perfectly well for the drug to go inside the vessel. And a suboptimal work is not going to be good.
That's an excellent point. That I think we want to make sure that we bring that across to our audience. That your goal is ultimately to have an optimal angiographic result via IVUS, via extravascular ultrasound, not only via angiography, because there is limitation to even digital subtraction angiography. And most importantly, I think, Chris, what you mentioned is because of how complex these lesions, if you're treating 400 millimeter lesion length and you end up stenting the proximal cap or the distal CTO cap, that's a win for the patient, rather than placing a 400 millimeter length stent. And again, you have to deal with that down the road. We're not suggesting that stenting is not right, but we want to utilize it when it's actually helpful to the patient and helpful in taking care of them down the line. And I think in my practice, I've moved to that type of approach, trying to use scaffold when I think it will help optimize my angiographic or IVUS guided result toward the end. How do you guys think about that?
Yeah, absolutely. And the IVUS is a major player for me. It's at first years ago I would use it sparingly and wasn't sure convinced. I'm convinced at this point. I would have you'd have that patient where you fix him. You thought you did a great job, and in that first month back, in 5% of your patients they reocclude. And you're like, why do they reocclude? And now we know it's just that we're not seeing it on 2D angiography. So it's a 3D lesion, and you have to look at it on 3D, and that's really helps you figure out what to do.
So, taking this back to the traditional access approach, I guess we're going to talk about the pedal and radial, but the traditional groin access. What's your thoughts on closure, Ankur?
On closure devices?
Closure devices, manual closure. What's your algorithm? What's Dr. Lodha's algorithm in terms of like, hey, when do I use a closure device? When do I decide to use manual compression? What do you think?
I think overall I feel that the access and the closure is what really determines a patient experience. We may do a great job at a lesion, but all the patient remembers from the procedure is how the access was and how the closure was.
Absolutely.
And we cannot do a good job because now we're being judged based on patient satisfaction as well, along with patient outcomes.
Right.
So my approach will be, if it's a severely calcified femoral, if I'm thinking about it, the closure device would be an issue in those cases, and manual compression is probably going to be the way to go. And that is why alternative accesses have found so much of interest among the community, because they can minimize the use of closure devices.
So to you, there is clear no-nos to using a closure device. One of them is a heavily calcified anterior wall or a small vessel. Yes. You still follow those simple rules.
Yes.
It seems like you make your decision based on ultrasound images. Okay. How about you, Chris?
So it's the patients are most afraid of bleeding. They go home, they had someone bleed, or maybe they personally experienced that before. I think the way to think about closure is, before you ever put the needle in, you have to use ultrasound to figure out where the best ideal space is. And so oftentimes I'm alternative because I'm in the SFA, because it's a nice compressible vessel, and it's I know I'm going to get a good closure with that. I tend to use a closure that is that's going to seal. That's going to be a mechanical seal. I like that mechanical seal. And there's a couple of them out there that do that. But a lot of my patients, I just treat transtibial, and so my closure device for that is zero, other than a rolled up piece of gauze and some tape that holds it in place for 24 hours, and they walk home in an hour. And so I think that small, if you can go to a smaller vessel, and you have an atraumatic entry with the Terumo sheath, the chances of bleeding or complications very low. I know you were mentioning about your low experience. We have a very similar experience. In 1,000 patients, over 1,000 patients, the access-related complication was less than 1%.
Wonderful.
And why that's so important to me is because my colleagues will shoot me if I, mess up the tibial vessel, and I'm the vascular surgeon messing up the tibial vessel. So, I think I had to kind of prove to myself and
accountability
then to my
is
colleagues
important.
that I think this is safe, and you can handle the problems that do come.
And I gotta comment, like with our practice, we actually have a dedicated ultrasound imaging protocol at the beginning of a procedure with our interventional ultrasonographers. So things that we look at before we even get access to Chris's point is we look at vessel pulsatility, compressibility, pliability, and amount of plaque on the anterior wall. And that really makes the decision, like you mentioned. Do I use a closure device? Do I use an active suture-mediated closure device, or device like the AngioSeal where you have a foot plate? Do you use an external compression device? There's a lot of them out there. But really that decision is so much easier now that you're able to see these vessels with ultrasound and make that determination based on these objective, not only my feeling or your feeling or how am I feeling today, right? It's like you're actually seeing, okay, I'm not hitting calcium, I'm not hitting plaque, that vessel is pliable, versus you touch it and it's basically a rock moving to the left and to the right. And I say, where's Chris to cut on this vessel and clean it up for us? But so this is really wonderful discussion. I really thank you for talking about this. I'm gonna switch gears a little bit and we're gonna lean on Dr. Lodha. You're one of the leaders in the field of R2P, which makes me and Chris jealous because we don't do as much in our practice. So one of the things that people ask about, what is your perfect patient, or I should not say perfect, ideal patient that you would consider R2P approach to?
I think 100% of the patients with anything less complicated, which would be anyway short segment SFA and down. Okay. I think pretty much every person should be considered for.
So can you elaborate like on SFA and down? Like, are we talking like a distal SFA?
No. Down means 100% short segment SFA or a 70, 80, 90% SFA, which is an open SFA with tight stenosis.
Gotcha.
Should really be considered for a traditional radial to peripheral.
So how often in your practice do you think like a lot of your patients would qualify for an R2P access?
In our outpatient lab, we are pretty much performing around 80 to 90% radial
80 to 90%. That's wonderful.
And very, very complex patients with long segment SFA CTOs, which are very calcified. Those kind of patients would probably benefit from other access sites. And part of the reason is because we have not reached a point where every device is available in radial lens. So I feel all the less complex patients should pretty much in an outpatient setting, when done radially, we've had great.
Do you ever marry the R2P platform to pedal form?
Yes. So the next part of this is if you have a complex long SFA CTO, we would use a combined radial with a pedal approach. We use the radial axis for visualization and then you use the dye to visualize it while we're working from the pedal axis, and then marry the wires, pull the wire up and then perform from one of the sides.
So the idea is to avoid the common femoral artery altogether. Absolutely. And reduce any chance of like unnecessary bleeding from the groin axis.
Yes.
So pedal-based revascularization, visualizing via radial axis. I've never thought of it that way, Chris, before. That's very interesting.
We always need to do it because sometimes you have, the CTOs are long and they're flush occlusions. And you want to try to stay true lumen, so you have to, if you're going to deliver therapy properly, you got to stay true lumen. You always have to image above. Yes. And so one way I've cheated a little bit was I would stick common femoral with a micropuncture and then a little dye, and you can see kind of where you're going to. But the advantage of transradial is that you can get a catheter and a wire and meet in the middle.
Yes.
And so there's some advantage of that. Otherwise, you are going to use a reentry device to get into your femoral, which is expensive and can be, get you into the wrong place sometimes.
Just to point out, along with your Navicross discussion, we have used an 035 Navicross from above and try to use an 018 Navicross from below, try to use the wires in cross-complex CTOs, and still use minimal invasive accesses for these patients.
That's really, you know what, you've definitely opened my mind to something.
Do you ever use just the catheters themselves?
And we married them together.
You marry the catheters together, even without a wire?
Yes, marry them together, and then the catheters meet together.
The Fadi technique,
and
is that right?
So I would like to mention that this is the physician's opinion. This is off-label use, advancing these catheters.
Yes,
but,
absolutely.
But it goes back to your point that you made earlier in terms of control with those catheters. You're not necessarily using brutal force. You're really able to control the movement. So that's actually a great. I'm going to try that because I do what Chris said. Actually, cheat with a micropuncture, but that might be actually a nicer way of doing it. And you don't have to approach the common femoral artery altogether. Can you comment? I know that there's R2P registry. That first of all, I think it's important that companies have to track their own outcomes, and I want to congratulate Terumo on doing so. And would you be kind enough to share with us some of these outcomes with this registry in terms of R2P, in terms of Mesago stent, in terms of balloon angioplasty?
So after the radial platform was launched, we've had quite a few studies in R2P registries. One of the multi-center registries we had, 120 patients were enrolled in that, and there was a separate arm in that where Mesago stents specifically were studied. The presentation was just was done at PCT, where we had a subset of Mesago patients in the registry with 68 patients who received Mesago stents, and there was 100% patency at 30 days, and 98%, if I remember, patients had resolution of their claudications.
Any complications with R2P platform?
We did not.
No
all the
complications.
access sites were, yes.
No, like hematomas.
We had. If you look at the data that we had from the REACH PVI study, where you'd use the CSI Diamondback catheter, we had 49 successful cases through the radial access.
But in your experience, you have not noticed a high rate of access site complications related to radial access?
The only things that we have noticed, but they were not access related, were when people were using radial accesses, they were using hydrophilic wires as their access wires. And when it goes into this radial artery, it sometimes chooses a small branch and may cause some microperforation. And with, on top of anticoagulation, people would develop forearm hematoma or pain. That was, I don't think, was related to the access, but using probably not the same wires.
More
operator dependent. Radial artery occlusion has been spoken a lot of times as people who don't want to do radial access. I feel that these are clinically silent events, and number two, a lot of these radial arteries will self-recanalize, and in the future we have actually accessed occluded radial arteries back with absolutely no problems or spasms.
And you and I are cardiologists, so we're a little bit biased because we know that there's a huge body of literature looking at coronary-based, radial-based interventions. And that number is not zero, and it has to do with anticoagulation and the size, maybe 5 to 7% depending on the coronary trial that you look at. But showed over and over again that radial access is superior to common femoral artery access simply because of a lower risk of complications associated with it. And I don't see that should not be replicated in the R2P platform. I think if anything, it should highlight it more.
Absolutely.
Yeah.
The only comment I have this as a surgeon in this arena is that you can have thrombosis. It is a possibility to have a thrombosis, and if the patient does have pretty significant hand ischemia, I want to be called right away. Because a simple thrombectomy solves the problem, saves the hand, and saves the patient. So
thank you. That's an important point.
It's a very good important thing that we work together on both of those.
Absolutely. That is actually a very important point. Thanks for mentioning that, Dr. LeSar. All right, so I want to focus the last few minutes here to just kind of get a glimpse into your brilliant minds in terms of what do you see on the horizon for PAD or CLI. If I say, Dr. Lodha, Dr. LeSar, you have a Pandora's box here. What's your wish list? What do you want to ask industry to do? What do you think is lacking or you would like to see more of in the field of PAD or particularly CLI therapy? Chris, we'll start with you.
I think the biggest thing we deal with all the time is the kind of that is the debulking of the disease that's there, and a lot of the devices are effective, but not as effective as I really want them to be. So I think something that's going to cause low perforation, but has a high efficacy in trying to remove that plaque. I think that's really critical. And we're starting to get some of that with some of the devices now. We have 6 or 7 different atherectomy systems that we constantly use. And we try to apply them to each patient. So I think that the technology is definitely, between now and 5 years ago, dramatically different. And I think there's more to come. I think the lithoplasty is fascinating when we use it, how to use it. The knowledge of how to deal with as the arteries recoil. How do we think about that? Just the simple technique of ballooning properly, ballooning right size is so critical. We're still learning a lot. I think we're still learning a lot. Even the simple things are important.
Great points. Ankur, what are your wish lists?
My wish list would be, number one would be a long length IVUS catheter.
Long length IVUS catheter, okay.
So 150 is the longest length IVUS we have, and as much as IVUS provides information to us, I should be able to IVUS all the way down from radial approach to a popliteal pedal. We need long lengths drug-coated balloons that could be compatible with radial access, and atherectomy catheters. Only one dedicated atherectomy catheter from CSI Diamondback.
Right.
And I wish other companies look at that and
consider longer devices.
Consider longer
Yeah,
devices.
those are great points. For me, and I know I've shared this with you, Chris, before with you, Ankur, but I really would like to see a larger platform for transtibial approaches. I know there's the same way there's investment in the R2P space. I think one of the points you mentioned is the closer you are to the lesion, the more effective and probably the safer you are in treatment. And what I would like to see is a little bit of a larger platform in terms of sheath catheters that will support a transtibial approach, AT to PT, PT to AT, in a further safer way when we're tackling those patients. And I think the technology is there, the platform is there. We just need to convince industry that the demand is also there.
I mean, there's a reason why that's your primary way of doing it. There's a reason why that's my primary way of doing it. There's, one thing is I'm always operating and I'm sitting near the foot. I'm 6 foot from the radiation. You're axial to the disease. You're not having to go up and over and do all the tortuosity. You're closer to the disease. You can get more push with the catheters because you're close. You use less contrast because you're just doing segments instead of doing large runoffs. So I think there's a lot of advantages to the transtibial approach. And unfortunately, the hospital systems, the fixed units don't really let you work from the foot as well. But the outpatient experience where I have a C-arm that's mobile, it is. I have much more ability to actually take care of patients with that C-arm than I do with a fixed unit right now.
Let me put it this way. The future of peripheral intervention is in the outpatient lab. It's in the ASCs and the outpatient labs, and patients will be moved away from the hospitals because it's convenient, it's better for the healthcare system. And as we move less invasive with tibial access or radial access, which effectively is able to discharge these patients safely, that's where all the work will be performed. So industry has to follow this. Or there will be somebody who'll find that.
I mean, don't you think that we as healthcare providers that tackle this disease on a daily basis, we really tailored the centers really around the needs of the patient? And maybe I'm tooting our own horn a little bit here, but that's the truth though, because Chris, I've been in your lab, and I've been in your lab. I mean, I see that you really built the center truly around the needs of that patient.
And the doctors. Okay, so it's designed for me to be most effective.
Right.
It's also designed for the patients to have the best experience.
Right.
And I just had this thought, though. You're right. I think it is going to be outpatient in a lot of the day-to-day work that we all do. We really need to have from industry better support from the payers. I need the industry to work with the payers and try to deal with it, because DCB is great. when do we use it in a 300 millimeter case? I don't really know. We'll eventually figure that out. But how do you pay for it? And my job is to fix patients, make them better, make them walk, because if they walk, they live. And the industry side needs to make sure that the regulatory works and that the payers work, so that we can, if Blue Cross owns that patient and I use a DCB and I don't have to do a second or third operation, Blue Cross wins. But they also need to be able to pay for the DCB in the outpatient world.
Right.
And so there's a big disconnect here between our knowledge and what's really happening in the world, because we don't have that support.
Right. And on that note, I second your comments, Chris. That's a discussion that we can spend days, venting our frustrations and expressing our opinions on. But I think it's important. I think it's important that we need to reach out to the payers and increase the level of knowledge, because you and I know, all of us know, that the level of knowledge of what gets done is minuscule, the reality. All right, so I want to take this opportunity and thank my co-presenters. Dr. Chris LeSar, thank you very much for being here today. Really, your input is valuable beyond description, and your scope of practice is really enlightening to a lot of people, including myself. So thank you for being here with us today.
Fadi.
Dr. Lodha, thank you so much for sharing your experience. I know that I learned something today. I actually did not think of it, that actually might pursue me to utilize R2P a little bit more in my practice. And thank you for sharing that information. And for our attendees and people that view this talk, my name is Fadi Saab. Thank you very much for listening to us today. We hope you found this presentation helpful, and we look forward to seeing you in future presentations. Thank you.